So we took 122 patients with myelodysplastic syndrome and myeloid malignancies who treated at our institution between 2000 and 2012 and received treatment with AZA or decitabine for at least 4 cycles. We used a panel of 62 gene mutations that have been described as the most recurrent somatic mutations in myeloid malignancies and MDS. And we then looked at patients who received the treatment, and we divided them into responders and non-responders. And responders were patients who achieved a complete remission, partial remission, or hematologic improvements. And then we look at the mutation distribution between each group. And what we found, some mutation has higher prevalence among responders, such as TIT2, IDH1, or IDH2, as well as cohesion mutations such as TAC2 and RAD21, whereas mutation in ASXL1 were more prevalent in non-responders to hypomethylating agents. Then we took those mutations and we added age and IPSS to control for clinical variables, and we put all this together into multivariate analysis, and then we constructed from the multivariate analysis the important prognostic factors that impact the response. And we then used the beta coefficients of each factors to build up a new model. And the model actually based on those genomic data. So if the patient has a mutation in TIT2, IDH1, or IDH2, they get a score of 1. If they have a mutation in STAC2 or RAD21, they get a score of 2. And if they have mutation in ASXL1, they get a score of minus 1.5. And then based on this score, we calculated the probability of response to hypomethylating agents. So for example, if the patient has a score of 2 to 3, they have up to 85% chance to response to hypomethylating agents, whereas if the patient has a score of minus 1.5, they have about 18 to 15% chance of responding. So we believe that this model can be used in the clinic to identify patients who may have a higher chance of response to hypomethylating agent and surrogate the patient who may not respond to such therapy so they can treat it on a different basis.